it does also present, the patient will note impaired visual performance. Some other physical exam findings will be your cognitive impairments. This is a big one that's going to overlap. And you're going to see things like decrease in attention, abnormalities in attention, executive functioning, abstract conceptualization, short-term memory loss, word recall, and abnormalities with speed of information processing. So just to kind of put that succinctly here, it's mainly the attention, decreases in attention. And it's also important to note that dementia could be a possibility, but it is really rare, and it's seen in less than 5% of MS patients. We also see a lot of motor symptoms. And with this, you're going to see incoordination. This is going to kind of be split into two sections. So incoordination or spasticity, or both. So with incoordination, you're going to see gait imbalances, difficulty in performing coordinated actions with the arms and the hands, and slurred speech often occurs as a result of impairment with cerebellar pathways. The speech can come out kind of as scanning speech or explosive speech. And then we have spasticity. So again, you may see legs that are most commonly spastic, but it can also be in the cervical neck muscles, the pelvic floor, the fingers, the toes, and the axial paravertebral muscles. And this is more prominent at night, which leads us to our last physical exam finding, which is sleep disturbances. Oh, I lied, and one more, but we'll talk about that after. So sleep disturbances can consist of restless leg syndrome, obstructive sleep apnea, periodic limb movements, which goes along with the spasticity, and REM sleep behavior disorder, and narcolepsy. So the reason that I put this under the physical exam findings and not in the history, it can go in either or, but obviously if the patient's in your office and you send them for a REM sleep study because they're telling you they can't sleep at night, you're the one that's going to find that, not them. They're not going to know they have REM sleep behavior disorder. But again, you would also probably be in the same position with obstructive sleep apnea, but they could probably report to you the restless leg syndrome or the narcolepsy. And same with our last finding, which is epilepsy. So this can happen to MS patients, and again, it's here because obviously if they have an episode in the office or in the hospital, it would be a finding that you would find, but it could also be reported as a patient history. So moving on to testing. A big important thing to note here that I really want to bring home so that you can remember this, is that there is no single test for MS. So I'm going to put that in green. Oh no. Let me fix that real quick. Messing up everything. Okay, so there's no single test to diagnose MS. What we usually go by is the McDonald's criteria, which composes of clinical examination and MRI confirmation. So for clinical symptoms, we are going to see there's going to be some qualification, and the main thing is patient has to have greater than two episodes lasting at least 24 hours and occurring at least 1 month apart. These signs and symptoms would be of brain or spinal cord disease not attributable to another diagnosis. So anything here that we wouldn't be able to rule out MS. So, what did I have here? 2 episodes. And 1 month apart. Okay. And now the second part, which is the MRI confirmation, you're going to be seeing 2 things from this MRI confirmation: dissemination in space and dissemination in time. So dissemination refers to the lesions in the brain that you would see in MS. Dissemination in space we'll talk about first. And again, referring to the demyelination plaques, that would be both active or inactive. And you have to qualify with 2 of the following. So periventricular, cortical, juxtacortical, infratentorial, spinal cord lesions, or optic nerve lesions. And for all of those that I just named, you would have to have at least 1 or more lesions in that area, except for the periventricular. You'd need to have 3 or more lesions in this area. So let me just kind of put that here for you. So we would have plaques, inactive and active, and then we're going to have all the different types.